This is the case of multiple recurrent renal calculi leading to non-functioning kidney on left side. This is a 55-year-old elderly lady with history of one open pyelolithotomy followed by two abandoned PCNLs and one PCN placement for pyonephrosis and multiple histories of pyelonephritis in the past. So in view of non-functioning kidney with history of multiple episodes of infections in the past, we had taken up the patient for lap nephrectomy, and as expected was not an easy case. We had to actually dissect more cranially than the usual dissection, and only after a while we could identify some kidney anatomy because it is all adhered all around. So we used ligature and gentle dissection was started because wherever we were trying to dissect, the patient was bleeding, and we had to do it with utmost care and gentleness. And after a while, for the very first time, we could identify renal vein, and only then we started going more confidently towards the other part of the surgery. And once a renal vein was identified, it was gently dissected, and then every possible effort was made to identify the renal artery. And as expected, because of adhesions, even this renal artery identification was very difficult. So we had to clip and divide and ligate every possible structure which was looking like a renal artery because of multiple interventions and infections. Everything was looking like a cord around the hilum. And because we could not get that good leverage to lift the kidney, we had to dissect it some more cranially towards the spleen, and then slowly started going towards the hilum. And after a while, after doing some more dissection with the help of ligature, we started seeing a cord-like structure behind the renal vein. And this was the first glimpse of the renal artery that we could see. And once we were a bit confident that this could be the renal artery, we tried to clip it, but because of space constraint we could not clip it properly. So what we did was we just clipped it and then left it, then clipped the renal vein so that we can get some more space, after making sure that that's the only renal artery of the patient. And once renal vein was cut and we observed that there is no congestion of the kidney and no more bleeding from anywhere, we clipped the renal artery confidently and then divided it. And once the renal artery and vein were divided, we thought the job is over, and now it's just cut and dissect and remove the kidney. But because of multiple interventions, the actual story started here, because reaching up to this point it almost took 40-45 minutes, but the rest of the surgery took more than an hour because the intervention was extraperitoneal all the time. The adhesions were dense posteriorly, and because of pyelolithotomy, getting up to renal pelvis and identifying ureter was very difficult. So the patient was bleeding wherever we were trying to use ligature. So we just started clipping blindly, because now that the hilum is dealt with, we're not going to injure anything new. So the dissection was continued with the help of ligature, but it was not helpful because of dense adhesions around the renal pelvis and posteriorly. And this is the site of PCN placement in the past. You can see the tract. We were trying to cut it. It was not happening. So we thought of shifting to a monopolar current because ligature was not helping. So we started using a hook. That helped a bit actually. So we could dissect the posterior convex surface of the kidney from the abdominal wall to release it from those adhesions. And once we decided that ligature is not going to help anymore, we used scissors liberally around the renal pelvis, and in fact we had to cut some tissue of the renal pelvis just to make sure that whatever kidney we could remove. And in attempt of removing the kidney with the help of scissors, we opened up pelvis, we removed few stones, and finally we could remove the specimen almost completely. And once the specimen was removed, a thorough wash was given, ensuring no more bleeding.